Welcome to the deep dive. Today we're tackling something really fundamental to how our bodies respond to serious illness and injury. Shock, hemorrhage, and transfusion.
Yeah, these are absolutely crucial concepts.
And they aren't just, abstract medical terms. Understanding them offers a powerful lens, I think, through which to view the body's incredible capacity to cope under extreme duress, but also its breaking points.
Absolutely.
We've got a rich stack of established surgical knowledge here, and our mission really is to extract those core insights, maybe the aha moments. It'll give you a much deeper understanding of what's actually happening when the body faces a critical challenge to its survival.
Exactly. We're not just skimming the surface today. We're aiming to dive deep into the underlying mechanisms that govern these life or death situations.
Okay.
We'll explore the different facets of shock and hemorrhage, how they're identified, and the strategies used to manage them. Think of it as gaining a fundamental understanding of the body's response to a major crisis.
Okay, let's unpack this then, starting right at the foundation. Shock. What exactly is happening in the body when someone goes into shock?
Well, at its most basic level, shock is a state where the body's tissues simply aren't getting enough blood flow to function properly.
So not enough perfusion.
Right. This means there's a shortage of vital oxygen and nutrients reaching the cells, and that disrupts their normal way of working, what we call cellular respiration.
Okay, so it's like the body's engine isn't getting enough fuel, essentially.
Yeah.
What happens right down at the cellular level when this fuel shortage occurs?
Well, when cells are starved of oxygen and glucose, they have to switch gears. They move to a less efficient way of producing energy called anaerobic metabolism.
Anaerobic, without oxygen.
Exactly. Think of it maybe like switching to a backup generator that produces a lot of, exhaust. In this case, that exhaust is lactic acid.
Ah, okay.
As more and more tissues experience this low blood flow, lactic acid starts to build up in the bloodstream. This makes the body's internal environment more acidic, a condition we call systemic metabolic acidosis.
So this backup energy system, while it keeps things ticking over temporarily, creates its own set of problems with this acid buildup. What happens next as the oxygen deprivation continues?
Right. And this backup system, it can't run forever. The cell's internal stores of glucose eventually run out.
They get depleted.
Yeah, and even this inefficient anaerobic metabolism starts to grind to a halt. This energy crisis then leads to the failure of these crucial pumps in the cell membranes and also within the tiny compartments inside the cell, the organelles.
Pumps. Like gatekeepers?
Kind of, yeah. Think of them as gatekeepers, constantly moving sodium and potassium ions in and out to maintain the cell's electrical balance and function. When they fail because there's no energy, this balance is completely disrupted.
And what are the immediate consequences of these gatekeepers failing?
It's pretty severe for the cell. Tiny sacs within the cell called lysosomes, which contain powerful digestive enzymes, they actually rupture.
Oh, wow.
And these enzymes then start to break down the cell itself, a process called cell lysis. It's essentially cellular self-destruction.
So the cell digests itself.
In a way, yes. And as the cell breaks apart, its contents, including a lot of potassium, are released out into the bloodstream.
So it's not just an oxygen shortage, it's this whole cascade of destructive events happening inside the cells, releasing harmful substances. Now let's zoom out just a little to the very small blood vessels, the microvascular level. What's going on there?
Right. As tissue ischemia, that lack of blood supply persists, the local environment becomes really stressed. This triggers our body's defense and repair systems, the immune system and the coagulation or clotting system.
They'll kick in.
Yeah. The low oxygen levels, hypoxia, and the increased acidity, acidosis, they activate a part of the immune system called complement and also prime our white blood cells, the leukocytes, making them much more reactive.
Primed for action.
Exactly. And this activation leads to the production of damaging molecules called oxygen-free radicals and also the release of signaling molecules called cytokines, which further amplify that inflammatory response.
How do these events affect the delicate walls of our smallest blood vessels, the capillaries?
Well, these processes directly damage the cells lining the capillary wall, the capillary endothelial cells. And this damage then further kicks off the immune and coagulation systems. It becomes a cycle.
Right.
The normally tight junctions between these endothelial cells loosen up, and the vessel walls become, leaky. Fluid starts to seep out of the capillaries into the surrounding tissues, causing swelling, or edema.
And that swelling must make things worse.
It absolutely does. Unfortunately, it makes the oxygen shortage even worse because the oxygen now has a greater distance to travel to reach the cells that need it. It's a real vicious cycle where the body's attempt to respond actually creates further problems.
The self-perpetuating problem. And you mentioned those damaged cells releasing potassium earlier. What impact does that have at this microvascular level?
That released potassium enters the bloodstream, contributing to what we call systemic hyperkalemia, a dangerously high level of potassium in the blood, and it also further worsens the acidosis. Plus, these released intracellular components act like alarm signals to the rest of the body, causing even more widespread activation of the immune system.
Okay, so from the very small scale of cells in microvessels, let's zoom out again to the bigger picture, the systemic cardiovascular effects of shock. How does the heart and the whole circulatory system initially respond to this overall lack of perfusion?
Well, when the amount of blood returning to the heart that's the preload decreases, and the resistance the heart has to pump against the afterload also drops, the body senses this change in blood pressure very quickly.
How does it sense that?
Through specialized sensors called baroreceptors, they trigger a compensatory response. This leads to increased activity of the sympathetic nervous system, the fight or flight response, and the release of hormones like adrenaline and noradrenaline, which we collectively call catecholamines, into the bloodstream.
Right, the stress hormones.
Exactly. The typical result is an increased heart rate, tachycardia, and the narrowing of blood vessels throughout the body, systemic vasoconstriction. This is all aimed at trying to maintain blood pressure and prioritize blood flow to the most vital organs.
Makes sense. Squeeze the pipes.
Yeah, basically. However, it's really crucial to remember that in septic shock, a type we'll definitely discuss later, we often see the opposite, widespread vasodilation or opening up of the blood vessels.
Okay, that's an important exception. So the body tries to squeeze the existing blood volume to keep critical organs supplied. What about the respiratory system? How does it get involved?
The metabolic acidosis we talked about earlier, combined with that increased sympathetic response, leads to an increase in both the rate and the depth of breathing. We call this increased respiratory rate and minute ventilation.
Breathing faster and deeper.
Right. This is the body's attempt to blow off more carbon dioxide, which is also acidic when dissolved in blood. By getting rid of CO2, the body tries to counteract the metabolic acidosis by creating a compensatory respiratory alkalosis, making the blood slightly more alkaline.
Trying to balance the pH. Now, how do the kidneys react to this situation of low blood flow? They must be affected.
Oh, definitely. The reduced pressure of blood flowing into the kidneys directly reduces their ability to filter waste products. The filtration rate at the glomerulus, the kidney's filter unit, decreases significantly.
Leading to less urine.
Exactly. It leads to a decrease in urine output. Additionally, the reduced blood flow triggers the renin-angiotensin-aldosterone axis, or RAAS. This is a really powerful hormonal system.
RAAS, I remember that.
Yeah, it causes further narrowing of blood vessels and also increases the reabsorption of sodium and water by the kidneys. This is yet another compensatory mechanism aimed at boosting blood volume and pressure.
And finally, what's the endocrine system's involvement? The hormones.
The endocrine system, our network of hormone-producing glands, plays a vital role. As we've sort of touched on, the adrenal glands and the renin-angiotensin system are activated. Furthermore, a hormone called vasopressin, which you might also know as antidiuretic hormone, or ADH, is released in response to the decreased blood volume returning to the heart.
Vasopressin, ADH, what does it do?
Well, vasopressin causes blood vessels to constrict and also increases the amount of water reabsorbed by the kidneys, specifically in the collecting system, so it helps retain fluid. The adrenal cortex also releases cortisol, the classic stress hormone.
Cortisol, too.
Yes. Cortisol contributes to sodium and water retention and also, importantly, makes the body's cells more sensitive to the effects of those catecholamines like adrenaline, enhancing their ability to constrict blood vessels. So you see, it's a truly orchestrated, whole-body effort to try and maintain essential functions when the body's perfusion is compromised.
A massive coordinated response. Okay, that gives us a really solid understanding of the underlying pathophysiology. Now let's move on to understanding how shock is classified. You mentioned there are different types.
Absolutely. While shock is fundamentally about inadequate perfusion, it can actually arise from different initial problems. And categorizing shock based on its primary cause is really helpful clinically for understanding what's going wrong and therefore how best to treat it.
And can someone have more than one type?
Yes, that's a key point. Sometimes a patient can experience more than one type of shock at the same time, which obviously complicates things.
Okay, so what are the main categories we use to classify shock? How many are there?
We generally break it down into 5 main categories. These are hemorrhagic or hypovolemic shock, cardiogenic shock, obstructive shock, distributive shock, and finally, endocrine shock.
5 types. Let's start with maybe the most common one. Hemorrhagic and hypovolemic shock. What's the underlying issue here?
Okay. Hypovolemic shock, at its core, is caused simply by a reduction in the total volume of blood circulating in the body. Low volume.
Hypovolemia, low volume.
Right. This reduced volume can be due to actual blood loss, which we specifically call hemorrhagic shock, or it can be due to a loss of other body fluids, which we term non-hemorrhagic hypovolemia.
What causes non-hemorrhagic loss?
Well, things like not drinking enough fluids, leading to dehydration, losing excessive fluids through severe vomiting or diarrhea, or excessive urination like you might see in uncontrolled diabetes. Even evaporation from the skin, for example, with extensive burns, can cause significant fluid loss.
Burns, right.
And another important concept here is something called third spacing. This is where fluid shifts out of the blood vessels and into other compartments in the body, like the tissues or body cavities, where it's not readily available for circulation. We see this in conditions like a blocked bowel or severe pancreatitis.
So even without obvious bleeding, a significant loss of fluids can still lead to this state of low circulating volume.
Exactly, and it's critical to grasp that hypovolemia is actually the most frequent form of shock we encounter. And to some extent, it plays a role in almost all other types of shock as well.
Really? In all the others too?
Well, often as a complicating factor or a later development. So no matter what the primary cause of a patient's shock appears to be, we always have to consider and rule out or treat any absolute loss of fluid volume or even a relative loss where the blood vessels have expanded too much for the existing volume. Volume status is key.
Okay, always think about volume first. Let's move on to the second type, cardiogenic shock. What's the core problem in this type?
Cardiogenic shock arises when the heart itself fails to pump blood effectively enough to meet the body's needs. The pump isn't working.
The pump fails.
Exactly. This can be triggered by various heart problems, such as a myocardial infarction, a heart attack where part of the heart muscle is damaged. Or it could be cardiac dysrhythmias, irregular heartbeats that prevent the heart from pumping efficiently.
Like AFib or VTAC.
Precisely. Also, valvular heart disease, where the heart valves aren't working correctly, blunt trauma to the heart muscle itself, and cardiomyopathy, which is a disease of the heart muscle.
So direct heart problems.
Yes, but also the heart's pumping strength can be weakened by internal factors, like the toxins released during a severe infection like sepsis, or by external factors such as certain medications or even drug abuse.
So sepsis can cause cardiogenic shock too.
It can cause myocardial depression, which contributes to the overall shock state, yes. A key sign that might accompany cardiogenic shock is evidence of increased pressure in the veins, which can lead to the fluid buildup in the lungs, pulmonary edema, or in other parts of the body, systemic edema.
Right, the fluid backs up because the pump isn't moving it forward. Okay, so in cardiogenic shock, the problem is fundamentally the heart's pumping ability. Now, what about obstructive shock? What's causing the obstruction here?
In obstructive shock, the heart muscle itself might actually be perfectly healthy, but its ability to fill with blood properly is hampered by some kind of physical obstruction.
Something blocking the flow.
Exactly. Common causes include cardiac tamponade, where fluid builds up rapidly in the sac around the heart, compressing it and preventing it from filling properly.
With squeezing the heart.
Yeah. Another is tension pneumothorax, where air gets trapped in the chest cavity under pressure, squeezing the heart and the major blood vessels. Also, a massive pulmonary embolus, a large blood clot blocking blood flow through the lungs prevents blood from getting back to the left side of the heart. Or even an air embolus, where air bubbles block blood flow.
So these are all things physically stopping the heart from filling or ejecting blood.
Correct. In all these scenarios, the filling of the heart chambers is reduced, leading to a low cardiac output simply because the heart doesn't have enough blood coming into it to pump out.
Okay, those sound like critical emergencies. Let's move on to distributive shock. You mentioned this one has some very distinct characteristics, especially in cases like sepsis.
Yes, distributive shock is characterized by this widespread pattern of blood vessel responses that leads to inadequate blood flow reaching the organs, even though the heart itself might be pumping adequately or even excessively, especially in the early stages.
So the distribution is the problem.
Precisely. We see this in conditions like septic shock Anaphylaxis, that severe allergic reaction and neurogenic shock, which can result from a high spinal cord injury. The hallmarks are widespread dilation of blood vessels.
Vasodilation.
Right, leading to low blood pressure, a characteristically low systemic vascular resistance, meaning the vessels are too open or relaxed, an inadequate afterload for the heart, and often, paradoxically, in the initial phases, an abnormally high cardiac output.
High cardiac output, but still not enough perfusion. That sounds counterintuitive. How does that work?
It does seem odd, doesn't it? But it's because the blood isn't being effectively distributed to the tissues where it's actually needed. For example, in anaphylaxis, the widespread vasodilation is caused by a massive release of histamine.
From the allergic reaction.
Exactly. In neurogenic shock from a high spinal cord injury, there's a loss of the sympathetic nervous system signals that normally keep blood vessels toned, leading to widespread relaxation and dilation.
The control system fails.
Right. The mechanism in septic shock is a bit more complex. It involves toxins released from bacteria, like endotoxin, and an overwhelming activation of the body's own immune system. This leads to a maldistribution of blood flow at the microscopic level.
How so?
Well, you get things like arteriovenous shunting, where blood bypasses the tiny capillaries that are supposed to deliver oxygen to the cells, and also there's often an impairment in the cell's ability to actually use the oxygen that is delivered.
So even if oxygen gets there, the cells can't use it properly.
In some cases, yes. That's a key feature of septic shock. And it's important to note that in the later stages of septic shock, patients can also develop hypovolemia because fluid leaks out of those leaky blood vessels we talked about earlier, and the heart muscle itself can become weakened myocardial depression, further complicating the picture.
Wow, sepsis sounds incredibly complex. So the pipes are wide open, maybe the pump is working hard, but the blood isn't getting where it needs to go effectively, or it can't be used. Finally, let's discuss the fifth type, endocrine shock.
Right. Endocrine shock can sometimes present looking like a combination of hypovolemic, cardiogenic, or distributive shock. It arises from problems with the body's hormone-producing glands.
Which glands specifically?
Primarily disorders of the thyroid gland, both an underactive thyroid, hypothyroidism, and an overactive thyroid, hyperthyroidism, and also adrenal insufficiency, where the adrenal glands don't produce enough crucial hormones like cortisol.
How do these cause shock?
Well, in hypothyroidism, the shock state can resemble neurogenic shock. You get a blunted response of the blood vessels in the heart to stress hormones like adrenaline. The heart's pumping strength tends to be low, the heart rate is often slow, and in some cases there can be an associated weakening of the heart muscle, a cardiomyopathy.
So low thyroid activity slows everything down. What about high thyroid activity?
Conversely, in thyrotoxicosis, or hyperthyroidism, the hugely increased metabolic rate can sometimes lead to a very high cardiac output state that eventually results in heart failure, a kind of high output failure.
High output failure, okay.
And adrenal insufficiency. Adrenal insufficiency, like Addison's disease, or sometimes a relative insufficiency seen in severe illness like sepsis, leads to shock through a combination of low blood volume and a poor response to the body's own stress hormones, and also to any vasopressor medications we might give. They just don't respond well.
So hormonal imbalances can have really significant and varied effects on the whole cardiovascular system, ultimately leading to shock. You mentioned a table earlier that summarizes the key cardiovascular and metabolic characteristics of these different types. Could you walk us through the main points of comparison?
Certainly. Table 2.1 gives a really helpful snapshot. Let's take hypovolemic shock first. Because of the low blood volume, cardiac output is low. The body compensates by clamping down the blood vessels, so systemic vascular resistance, SVR, is high. Venous pressure is low, not enough volume returning. Because tissues are pulling out more oxygen from less blood, the mixed venous saturation, SVO2, is low, and the lack of oxygen causes lactic acid buildup, so the base deficit is high, indicating acidosis.
Okay. Low volume, low output, high SVR, low SVO2. What about cardiogenic and obstructive?
Both cardiogenic and obstructive shock also result in a low cardiac output. Either the pump fails or it's blocked. The body again tries to compensate with high SVR. However, a key difference here is that venous pressure is high because blood is backing up behind the failing or obstructed heart. Like hypovolemic shock, the SVO2 is low due to poor delivery, and the base deficit is high.
High venous pressure is a key differentiator there. Now, distributive, that sounded different.
It is. Distributive shock, especially in the early warm phase of sepsis, often presents with a high or normal cardiac output initially. But the defining feature is the low systemic vascular resistance. The vessels are wide open. Venous pressure is typically low because the dilated vessels can hold more volume. And interestingly, the mixed venous saturation, SVO2, is often high in distributive shock, particularly sepsis.
High SVO2. Why?
It reflects that issue we discussed. Even though blood flow might be high, the tissues aren't able to extract and utilize the oxygen effectively due to cellular dysfunction or shunting. So more oxygen stays in the venous blood. Despite this, the base deficit is still typically high because overall perfusion and metabolism are profoundly disturbed.
That table really helps visualize the different physiological fingerprints. Now let's talk consequences. What happens if shock isn't recognized and treated effectively? What can happen to the body if it stays in shock?
If shock persists without adequate treatment, the consequences can be absolutely devastating. One critical potential outcome is what we term unresuscitatable shock.
Unresuscitate.
Yes. This happens when the body remains in a state of profound shock for a prolonged period. The lack of oxygen at the cellular level leads to widespread cell death, and eventually the body's initial compensatory mechanisms become completely overwhelmed and just fail.
How does that manifest?
In the heart muscle itself, poor blood flow through the coronary arteries, combined with the toxic effects of severe acidosis and high potassium levels, leads to a very weak cardiac output that simply doesn't respond to medications or fluids anymore. And in the rest of the body, the peripheral blood vessels lose their ability to maintain tone, resulting in persistent low blood pressure that doesn't respond to vasopressor drugs.
So everything just gives out.
Essentially, yes. Once the body reaches this point of widespread and irreversible damage from lack of oxygen, systemic ischemic injury, unfortunately, death is usually inevitable.
That's a very sobering outcome. What about this phenomenon you mentioned earlier, ischemia-reperfusion injury? It sounds like a double-edged sword. Like fixing the problem causes another problem.
It really is. Ischemia-reperfusion injury is a super important concept. During the period when blood flow is reduced in shock, the ischemia phase cells and organs suffer damage due to the direct lack of oxygen and also the triggering of local inflammation, as we discussed.
Right.
Paradoxically, further damage can occur when the blood flow is restored. That's the reperfusion injury.
How?
Well, the buildup of acid and potassium during the low flow period, when blood flow returns, can directly depress the heart muscle, cause blood vessels to dilate further, and lead to another drop in blood pressure. Additionally, molecules released from the damaged cells activate our white blood cells.
The inflammatory cell.
Exactly. These activated white blood cells, along with other inflammatory components that were activated by the lack of oxygen, things like complement, neutrophils, and tiny microvascular blood clots, they just overwhelm the body's local anti-inflammatory defenses.
The inflammation spreads.
Yes. When blood flow is restored, these inflammatory mediators are carried throughout the body, causing injury to distant organs that might not have been initially affected, like the lungs and kidneys. This can lead to acute lung injury, ALI or ARDS, acute kidney injury, AKI, swelling in the brain, cerebral edema, and ultimately multiple organ failure and death.
Can we prevent reperfusion injury?
Currently, the main way we can try to lessen reperfusion injury is by doing everything possible to minimize how severe the initial period of low blood flow is and how long it lasts. Early and effective resuscitation is key.
So while restoring blood flow is absolutely essential, it can paradoxically cause more harm if the initial period of oxygen deprivation was too severe or prolonged. And this can contribute to multiple organ failure, which you mentioned is maybe becoming more prevalent now as our initial resuscitation gets better. We save more people initially.
That's exactly right. Because we are now better at keeping patients alive through the initial shock episode, more patients are surviving long enough to develop the downstream consequences of prolonged oxygen deprivation and that reperfusion injury.
Which leads to MOF.
Yes, this can lead to damage in multiple organs, resulting in multiple organ failure, which we generally define as the failure of two or more major organ systems. Unfortunately, there isn't a specific cure for multiple organ failure itself.
So what do we do?
Treatment focuses on providing support for each failing organ system, for example, using a ventilator for lung failure, medications to support the heart and blood pressure, and dialysis or hemofiltration for kidney failure. We hope that the organs will eventually recover their function with this support.
But the outlook isn't great.
Despite these advanced supportive measures, the mortality rate for established multiple organ failure remains very high, often around 60%. This really just underscores, again, how critical it is to recognize and reverse shock as early and effectively as possible, ideally preventing this devastating complication from ever occurring in the first place.
And there's a summary box, box 2.2, that touches on the effects of organ failure.
Yes, it outlines some of the key manifestations. Failure of the heart leads to cardiovascular instability. Lung injury results in acute respiratory distress syndrome, ARDS. Kidney damage causes acute renal insufficiency or failure. Liver failure can impair clotting, leading to coagulopathy. And brain injury can result in cerebral swelling and dysfunction.
These are all clearly very serious and interconnected consequences. It really highlights the importance of early intervention. Now, how do clinicians actually recognize and diagnose shock in a patient? You mentioned earlier that it can sometimes be very subtle.
That's a really crucial point. While shock can sometimes present in a very obvious and dramatic way, making the diagnosis relatively straightforward, it can also be very subtle, especially in its early stages.
The compensated phase.
Exactly. This requires a careful and thorough clinical examination, often combined with more sophisticated monitoring of the cardiovascular system and the body's metabolic state. We often talk about this phase called compensated shock.
What's happening in the body during this compensated phase? What's the body doing?
In compensated shock, the body's initial defense mechanisms, those ones we discussed earlier involving the sympathetic nervous system and hormones, they kick in to try and maintain adequate blood flow to the most vital organs, the heart, lungs, and brain.
How? By sacrificing other areas.
Essentially, yes. It does this by reducing blood flow to less critical areas like the skin, muscles, and the gastrointestinal tract. The cardiovascular and endocrine systems work together to try and maintain the central blood volume and blood pressure.
So what would we see clinically?
Well, in this early stage, you might see very few obvious clinical signs other than perhaps an increased heart rate tachycardia and cool skin in the extremities, the hands and feet, due to that vasoconstriction and the effects of stress hormones like adrenaline.
So on the surface, the patient might actually appear relatively stable, deceptively stable.
Exactly. Deceptively is a good word. However, this apparent stability is only being maintained by the underperfusion of those less vital organs. Their cells are switching to that less efficient anaerobic metabolism, leading to the production of lactic acid and the beginning of tissue damage.
The beginnings of acidosis.
Right. Even though the patient's vital signs might seem okay, normal blood pressure, maybe just a slightly fast heart rate, a systemic metabolic acidosis is developing, and the body's inflammatory systems are being activated silently.
And if this goes unrecognized?
If this state of compensated shock persists for too long without being recognized and treated, it will eventually lead to multiple organ failure and death. We even have a term for this situation where the vital signs appear relatively normal, but there's still underlying inadequate perfusion.
What?
It's called occult hypoperfusion. Occult meaning hidden.
Occult hypoperfusion.
Yes. Patients who have evidence of metabolic acidosis, like a high lactate or base deficit, despite having seemingly normal urine output and stable heart and breathing rates for more than, say, 12 hours, have a significantly higher risk of dying, developing infections, and experiencing multiple organ failure.
So even if the initial vital signs don't scream shock, there could still be serious problems brewing beneath the surface. We need to look deeper. What happens when the body can no longer keep up this compensation? When does it decompensate?
That's when decompensation occurs. If the underlying problem, like ongoing blood loss or severe infection or whatever the causes, continues, the body's compensatory mechanisms eventually just become overwhelmed and start to fail. We then begin to see progressive problems with kidney function, breathing, and the cardiovascular system becoming much more obvious.
Is there a threshold? Like how much blood loss?
Generally speaking, the loss of around 15% of the total blood volume can usually be compensated for quite effectively, and blood pressure often remains relatively stable. However, once the blood loss reaches around 30 to 40% of the circulating volume, the blood pressure will typically start to fall noticeably. That's often the tipping point into decompensated shock.
And this progression leads to the different stages of overt shocks that we recognize clinically. Mild, moderate, and severe.
Yes, exactly. In mild or compensated shock, as we've discussed, you'll often see that tachycardia, an increased breathing rate, tachypnoea, perhaps a mild decrease in urine output, and the patient might seem mildly anxious. The blood pressure is usually still within the normal range, but you might notice a narrowing of the pulse pressure. That's the difference between the systolic and diastolic blood pressure.
Okay, and the skin.
The skin in the extremities will often feel cool and maybe sweaty, and the capillary refill time might be prolonged, although, as we'll discuss, that's not always reliable.
Right. What about moderate shock?
As shock progresses to moderate or uncompensated shock, the kidneys really start to struggle, and urine output typically falls significantly, often to less than 0.5 milliliters per kilogram of body weight per hour. The heart rate increases further, and the blood pressure starts to drop. The patient may become drowsy and perhaps mildly confused.
And severe shock.
In severe shock, the cardiovascular collapse is profound. The heart rate will be very high, and there will be a significant drop in blood pressure hypotension. Urine output will be minimal or completely absent anuric, and the patient might be unconscious with very labored breathing.
Okay, those are the classic stages.
Yeah.
But you've mentioned that relying solely on these classic cardiovascular responses can be misleading sometimes. What are some of the key limitations we need to be aware of when examining a patient for shock?
It's really, really important to be aware of these limitations. For example, while a prolonged capillary refill time is often taught as a sign of hypovolemic shock, it can actually be quite variable in adults and isn't a very specific indicator. Some patients in early shock might even have a brisk capillary refill.
And in sepsis.
Conversely, in distributive shock like sepsis, the skin might actually feel warm and the capillary refill can be rapid even when the patient is in profound shock. So you can't rely on it alone.
What about heart rate? Tachycardia.
Tachycardia is a common finding, yes, but it might be absent in patients who are taking beta blocker medications which slow the heart rate, or in patients who have a pacemaker that controls their heart rate.
Good point.
Also, what we consider a normal heart rate varies. A rate of, say, 90 beats per minute might seem normal, but if that individual usually has a resting heart rate of 50, then 90 is actually significantly high for them and indicates a compensatory response. And sometimes, paradoxically, in some younger, fit patients with penetrating trauma and significant bleeding, we can even see a slowing of the heart rate bradycardia rather than the expected tachycardia.
That's unexpected. And blood pressure. We think of low BP as the key sign.
We do, but hypotension is actually a relatively late sign of shock. Children and young, physically fit adults can maintain their blood pressure surprisingly well until very late stages, even with significant volume loss. They do this by increasing their heart stroke volume and clamping down their peripheral blood vessels very effectively.
So normal BP doesn't mean they're okay.
Not necessarily. They can be in severe shock with what appears to be a perfectly normal blood pressure reading. Similarly, elderly patients who normally have high blood pressure might present with a blood pressure that seems within the normal range for the general population, but it's actually significantly lower than their usual baseline and is indicative of shock for them.
And medications again?
Yes. Again, medications like beta blockers can mask the expected increase in heart rate. So diagnosing shock, especially early or compensated shock, can be quite challenging. It really requires careful consideration of the entire clinical picture, the patient's baseline state, their medications, and recognizing that these classic signs might not always be present or easy to interpret. You need a high index of suspicion.
These are really critical nuances to be aware of. Vigilance is key. Now let's shift our focus specifically to hemorrhage or bleeding. How does uncontrolled bleeding lead to shock?
Well, uncontrolled bleeding directly causes a loss of blood volume, leading to hypovolemic shock. And when the specific cause of hypovolemia is blood loss, we call it hemorrhagic shock.
I'll pull that.
However, it's really crucial to understand that hemorrhage, the act of bleeding, and shock, the state of inadequate tissue perfusion, are not exactly the same thing, although they are very often closely linked.
How so? Can you explain that distinction?
Sure. A patient who is actively losing blood right now might not yet be in a state of shock, especially if the bleeding is relatively slow or their body's compensatory mechanisms are still working well.
They're bleeding but not shocked. Yeah.
Right. Conversely, a patient might be in shock because of previous significant bleeding, but the bleeding itself might have actually stopped by the time we are assessing them.
And this distinction is really important for guiding how we treat the patient, isn't it? It changes the priority.
Absolutely. It's fundamental. The approach to resuscitation differs significantly depending on whether a patient is actively bleeding or not. In patients who are actively bleeding, the immediate and highest priority is to stop the bleeding. Hemostasis first.
Stop the leak.
Exactly. In patients where the bleeding has been controlled, or if it's stopped on its own, the focus of resuscitation then shifts to correcting the shock state itself and restoring adequate blood flow to the organs. So, recognizing whether a patient is actively hemorrhaging is a distinct and critical step, in addition to assessing whether they are in shock.
Got it.
Hemorrhage needs to be recognized and managed rapidly and decisively to minimize the severity and duration of any resulting shock. The fundamental treatment for hemorrhage is to arrest the bleeding, to physically stop the blood loss, not just to replace the lost volume with fluids or blood products, although the supportive measures are often necessary too.
Why is just replacing volume not enough if they're still bleeding?
Because simply pouring fluids or blood into a patient who is still actively bleeding will unfortunately lead to what we call physiological exhaustion. This is a dangerous state characterized by worsening problems with blood clotting, coagulopathy, a drop in body temperature, hypothermia, and an increasingly acidic internal environment, acidosis. It creates a downward spiral that can ultimately lead to death. You have to stop the bleeding first.
So the focus has to be on stopping the source of the blood loss, not just trying to replace what's being lost while the bleeding continues.
Yeah.
You mentioned earlier the pathophysiology of acute traumatic coagulopathy, ATC, that can occur in trauma and surgery. Can you explain what that is and why it's so dangerous?
Yes. In the context of significant physical trauma and major surgery, the combination of the tissue damage itself and the subsequent hypovolemic shock can rapidly lead to a serious problem with the body's ability to form blood clots. This is ATC.
How common is it?
Remarkably, it can develop within minutes of the injury in up to a quarter, maybe 25% of major trauma patients. And its presence is associated with a very significant fourfold increase in the risk of death.
4 times higher risk. What actually happens in ATC?
ATC is characterized by an excessive breakdown of blood clots, a state called systemic hyperfibrinolysis. You also see low levels of a crucial clotting protein called fibrinogen and problems with the function of platelets, those tiny blood cells that help form clots. So clots break down too fast and the building blocks aren't there or aren't working properly.
And this initial problem with clotting can then evolve into something even more complex, right? Kick?
Yes, exactly. ATC can progress into a more complex and multifaceted condition known as trauma-induced coagulopathy, or TIC. This evolution happens partly because of further derangements that can actually be caused by the very measures we take to resuscitate the patient.
Like what? How does resuscitation worsen it?
For example, giving large volumes of intravenous fluids and even red blood cell transfusions can dilute the concentration of the patient's own coagulation factors, which can worsen the pre-existing clotting problems. It's simple dilution.
Okay.
Additionally, muscles that aren't getting enough blood flow can't generate heat efficiently, leading to a drop in body temperature, hypothermia. This can be further exacerbated by giving cold intravenous fluids and blood products straight from the fridge. Heat loss during surgery, especially with open body cavities, is also significant.
And cold affects clotting.
Profoundly. Both severe acidosis and hypothermia directly impair the function of the enzymes, the coagulation proteases that are essential for the blood clotting cascade. So you get this vicious cycle. Worsening clotting problems lead to more bleeding, which worsens the shock, acidosis, and hypothermia, which further impairs clotting, ultimately leading down that path to physiological exhaustion and death if it's not interrupted.
The lethal triad, or diamond of death, as it's sometimes called. It's a really dangerous cascade. Now let's talk about the different types of hemorrhage we might encounter. There are several ways to classify bleeding, aren't there, based on different factors?
Yes, hemorrhage can be classified in several different ways, which helps us think about it systematically. One important distinction is between revealed and concealed hemorrhage.
Okay, revealed versus concealed.
Revealed hemorrhage is bleeding that is obvious and external. Think of a significant bleed from a cut artery, or a massive vomiting of blood hematemesis, maybe from a bleeding stomach ulcer. You can see it.
Right. And concealed.
Concealed hemorrhage, as the name suggests, is bleeding that is contained within the body and not immediately visible. This requires a high degree of suspicion and often specific investigations to identify and control.
Where can concealed bleeding happen?
In trauma, common sites are the chest cavity, the abdomen, the pelvis, behind the abdominal cavity in the retroperitoneum, or even within the limbs in cases of severe fractures with vascular injury. Non-traumatically, you might think of a slow occult bleed from the gastrointestinal tract or a ruptured aneurysm inside the abdomen.
Okay. What about classifying hemorrhage based on when it occurs relative to an injury or surgery? Timing.
Right. Based on timing, we categorize hemorrhage as primary, reactionary, and secondary.
Primary, reactionary, secondary.
Primary hemorrhage is bleeding that occurs immediately at the time of injury or during a surgical procedure, straight away. Reactionary hemorrhage is a delayed bleeding episode that typically occurs within the first 24 hours after the initial event.
Why would it restart?
It can be caused by a blood clot getting dislodged as the patient's blood pressure comes back up and their blood vessels dilate during resuscitation. Or it could be due to a technical issue during surgery, maybe a surgical tie slipping off a vessel.
Oh, okay. And secondary hemorrhage.
Secondary hemorrhage is a type of bleeding that happens much later, typically 7 to 14 days after the initial injury or surgery. It's often due to the erosion or sloughing off of the wall of a blood vessel and can be triggered by factors like infection developing in the area, pressure necrosis maybe from a surgical drain, or even the presence of an underlying malignancy eroding into a vessel.
7 to 14 days later, wow. And finally, is there a way to classify hemorrhage based on whether it can be controlled surgically?
Yes, that's another important practical distinction. Surgical versus non-surgical hemorrhage. Surgical hemorrhage is bleeding that is directly related to a specific injury to a blood vessel or bleeding from a specific point that is amenable to surgical control.
Like tying it off or stitching it?
Exactly. Using sutures, ligatures, clips, or sometimes interventional radiology techniques like angioembolization to block the bleeding vessel from the inside. Non-surgical hemorrhage, on the other hand, is often a more diffuse, generalized bleeding from raw surfaces or mucous membranes. It's usually caused by an underlying problem with the body's clotting system, a coagulopathy.
So you can't just stitch one spot.
Right. This type of bleeding may not be easily stopped by surgical means alone, although sometimes packing the bleeding area can help temporarily provide tamponade. The primary treatment for non-surgical hemorrhage is to identify and correct the underlying coagulation abnormality. Fix the clotting problem.
That's a really helpful breakdown of the different classifications. How do clinicians go about diagnosing active bleeding, especially when it's concealed or the situation is unclear? What clues do we look for?
One of the key ways to assess if a patient might be actively bleeding, particularly when the source isn't immediately obvious, is to monitor how their blood pressure responds dynamically to the administration of intravenous fluids. We give some fluid and see what happens.
The fluid challenge response.
Exactly. We can categorize patients into 3 groups based on this response. A responder is someone whose blood pressure shows a good and sustained improvement after receiving a fluid bolus. This usually suggests they might have lost some volume, but are probably not actively bleeding at a significant rate anymore.
Okay, good response means bleeding likely stopped.
Or is very slow. A transient responder will show an initial improvement in blood pressure after a fluid bolus, but this improvement isn't sustained and the blood pressure starts to drift down again.
Up, then down. What does that mean?
This strongly suggests that the patient is still actively bleeding, and the rate of bleeding is perhaps just slightly less than, or maybe equal to, the rate at which we are administering fluid. They're keeping up, but just barely.
Right. And the third group?
The third group is the non-responder. These patients show little to no improvement in blood pressure even after a significant fluid bolus. This is a very ominous sign and strongly suggests that the patient is bleeding rapidly and the rate of blood loss is greater than our ability to replace the volume with fluids alone.
So both transient and non-responders likely need urgent action to stop the bleeding.
Absolutely. They are highly likely to have ongoing active bleeding that needs to be identified and controlled urgently.
And how do we typically classify the severity or degree of hemorrhage? I remember seeing a table in textbooks that categorized blood loss into different classes, class 1 to 4.
Yes, historically, the severity of hemorrhage has been classified into 4 classes based on the estimated percentage of the total blood volume lost and the associated changes in vital signs like heart rate, blood pressure, respiratory rate, and urine output.
Based on volume lost.
Right. We know the average adult has around 5 liters of blood, roughly 70 milliliters per kilogram, a bit more in neonates. However, accurately estimating the amount of blood lost, especially internal bleeding, is notoriously difficult and often leads to underestimation.
Hard to measure blood on the floor or inside the body.
Exactly. While we can see external blood loss, quantifying the volume is tricky. In the operating room, we try to measure blood in suction canisters and waste-soaked sponges, but it's still an approximation. And it's also really important to remember that the hemoglobin level in the blood is not a reliable early indicator of the extent of acute hemorrhage.
Why not? Isn't hemoglobin what carries oxygen?
It is, but because you're losing whole blood red cells and plasma together, the concentration of hemoglobin in the remaining blood might not change significantly right at the beginning. It only starts to fall later as fluid shifts from the tissues into the bloodstream to try and compensate for the lost volume, diluting the remaining red cells.
Dilution takes time. So the classification table, table 2.3, is it useful clinically?
The traditional classification linking estimated blood loss percentages, like 15% for class 1, 15-30% for class 2, 30-40% for class 3, 40% for class 4, to typical changes in vital signs is conceptually useful. It helps us understand the expected physiological responses as blood loss increases. However, it's not really used in a strict prescriptive way in clinical practice to guide immediate management.
Why not if it links volume to signs?
Mainly because it's very difficult to accurately determine the percentage of blood loss in real time, especially in emergencies. And perhaps more importantly, there's a lot of individual variation in how people respond to blood loss depending on their age, their underlying health, like cardiovascular fitness, medications they're taking, and other confounding factors like pain or injury.
So a useful concept, but limited practical application for guiding treatment minute to minute. This brings us to a really critical area, hemorrhage resuscitation. How does our approach to treating someone with significant active bleeding differ from treating other causes of shock?
The priorities change, right?
They change dramatically. The goals and the methods of resuscitation are fundamentally different when a patient is actively bleeding. In this situation, the primary focus shifts entirely to achieving rapid hemostasis, stopping the blood loss and simultaneously supporting the body's own ability to form clots. This overall strategy is known as damage control resuscitation, or DCR.
DCR, stop the bleeding, support clotting.
Exactly. Now, if the patient has stopped bleeding, or if their shock is due to a different cause entirely, then our resuscitation efforts are aimed differently, focusing on correcting the underlying problem and restoring adequate blood flow and oxygen delivery to the vital organs using different strategies.
Okay, so the very first step in DCR, of course, is to recognize that significant hemorrhage is actually occurring.
Absolutely. And while obvious external bleeding is usually easy to recognize, internal or concealed hemorrhage can be much more challenging to diagnose, as we've said. The working principle should be, in any patient who presents with shock, initially assume the shock is due to hypovolemia until proven otherwise.
Assume low volume.
Yes. And then initially assume that this hypovolemia is due to hemorrhage until that possibility has been reasonably excluded.
Assume bleeding until ruled out.
Exactly. Once significant hemorrhage is identified or strongly suspected, it's crucial to immediately activate the institution's major hemorrhage protocol, or MHP.
The MHP triggers a team response.
Yes, it outlines the standardized multidisciplinary approach to DCR, bringing together surgeons, anesthetists, emergency physicians, blood bank staff, nurses, etc. The immediate resuscitative measures always start with the basics. Assess and manage the airway and breathing, and control any immediately life-threatening external bleeding using direct pressure. Simultaneously, we need to establish large-bore intravenous access quickly and draw blood for cross-matching in case blood transfusion is needed urgently.
And start fluids or blood.
In critical situations with suspected massive hemorrhage, we might need to start a transfusion immediately with emergency release blood, which is typically type O, while waiting for cross-matched blood. Fluid use is very cautious in DCR, as we'll discuss.
Okay. And once we suspect hemorrhage, the next crucial step is trying to find the source of the bleeding, right? Where is it coming from?
Yes, rapidly identifying the likely site of hemorrhage is essential. It's important to stress that this initial identification doesn't necessarily need to pinpoint the exact anatomical location with absolute certainty right away. The goal is to guide the next critical step in controlling the bleeding.
Like deciding.
Yeah.
Operating room, radiology, endoscopy.
Precisely. Does the patient need to go straight to the OR or to interventional radiology for angioembolization? Or maybe to endoscopy if it's an upper GI bleed? Clues can come from the patient's history, previous bleeds, known aneurysm, NSAID use, or from the physical examination, nature of any visible blood, abdominal tenderness, pelvic instability, signs of chest injury.
What about trauma patients?
For trauma patients in shock, the visible external injuries might suggest potential sites of internal bleeding, but it's vital to quickly exclude significant bleeding into the major body cavities, chest, abdomen, pelvis, using rapid bedside assessments. This usually involves chest and pelvic x-rays and a focused ultrasound scan of the abdomen, the FAST scan.
FAST scan, right.
The specific investigations we choose must always be appropriate for the patient's overall physiological condition. Someone in profound shock with obvious life-threatening bleeding needs rapid bedside tests, not a trip to the CT scanner. Whereas patients who are more stable can undergo a more methodical workup to pinpoint the source.
Tailor the investigation to the stability. You've mentioned damage control resuscitation, DCR, several times now. Can you elaborate on the key principles that underpin this whole approach to managing active bleeding?
Yes. Damage control resuscitation, sometimes called hemostatic resuscitation, represents a fundamental shift in how we manage patients with ongoing life-threatening bleeding. It prioritizes the rapid control of hemorrhage and the preservation of the patient's clotting ability over aggressively trying to normalize all their vital signs immediately.
Why that shift in priority?
The core reasoning is that while the patient continues to bleed, we simply cannot effectively correct the low blood pressure, the inadequate oxygen delivery, the low body temperature, or the metabolic problems like acidosis. Trying too hard actually makes things worse.
How so?
Because aggressive and repeated administration of large volumes of intravenous fluids, especially crystalloids like saline, actually exacerbates the problems. It dilutes the clotting factors, worsens hypothermia if the fluids are cold, worsens acidosis, and can also lead to low calcium levels, which further impair clotting.
So fluids can be harmful in this specific situation.
In excess, yes. The implementation of DCR strategies over the past decade or so, largely driven by military experience initially, has been associated with really substantial improvements in survival rates for patients with severe hemorrhagic shock. It works.
That's significant. So when do we use DCR?
DCR is specifically applied only while the patient is actively bleeding. Once hemostasis is achieved, the resuscitation strategy changes. DCR is based on 4 main principles, often visualized together.
What are the 4 principles?
1. Rapid hemorrhage control. 2. Damage control surgery. 3. Permissive hypotension. And 4. Avoidance of dilutional coagulopathy and active treatment of existing coagulopathy, often presented alongside warming and correcting acidosis calcium.
Okay, let's break those down. First, rapid hemorrhage control. What does that entail specifically?
This is always the absolute highest priority. For any external bleeding, direct pressure is the first step. Temporary control might involve tourniquets for limbs, pressure bandages, or even specialized devices like balloon catheters inserted into wound or body cavities to tamponade bleeding internally. If we suspect significant bleeding inside the chest or abdomen, we need to investigate urgently and expedite the patient to the operating room or interventional radiology for definitive surgical or radiological control. Stop the bleeding fast.
Right. Second principle, damage control surgery, DCS.
Yeah.
How does the surgical approach differ here? You said it's limited.
Yes. In damage control surgery, the surgical intervention is intentionally limited to the absolute minimum procedures required to stop life-threatening bleeding and perhaps control major sources of contamination or infection. We deliberately avoid extensive, time-consuming dissections, definitive anatomical repairs, like complex bowel reconstructions, or any procedures that might further stress the patient's already precarious physiology.
Fix the big problems, get out quickly.
Exactly. Those more definitive repairs are postponed until the patient is hemodynamically stable, warmed up, has their clotting corrected, and is generally better able to tolerate a longer, more complex operation, maybe 24, 48 hours later. The surgical approach is guided by the patient's immediate physiological state, keeping them alive, rather than achieving a perfect anatomical result in the first operation.
And there's a summary box 2.3 on this.
Yes, Summary Box 2.3 captures it perfectly. The goals of damage control surgery are arrest hemorrhage, control substance contamination, protect from further injury, and, importantly, nothing else.
Very focused. Okay, the third principle is permissive hypotension. This sounds counterintuitive again, like letting the blood pressure stay low.
It does sound counterintuitive because normally we're trying to raise blood pressure in shock. Permissive hypotension involves deliberately allowing the patient to maintain their own lower blood pressure while they are actively bleeding, rather than aggressively trying to force the blood pressure up to a normal level using large volumes of intravenous fluids or potent vasopressors early on.
Why would we do that? Why allow low pressure?
The rationale is that aggressively raising the blood pressure while bleeding continues can actually worsen the hemorrhage. Higher pressure can pop the clot, dislodge any early fragile clots that might have formed at the injury site, and increase the rate of bleeding from the injured vessels. It also worsens the dilutional coagulopathy and contributes to fluid-induced hypothermia if large volumes are used.
So keep the pressure low enough to reduce bleeding, but high enough for vital organs.
Exactly. We're not aiming for profound hypotension. We need to maintain a minimum blood pressure to ensure adequate blood flow to the vital organs, particularly the heart, coronary arteries, and the brain. Therefore, the target is usually to maintain just enough pressure to ensure perfusion of these critical organs, often judged by having a palpable central pulse, like the carotid or femoral, which generally corresponds to a mean arterial pressure, MAP, of around 50-60 mmHg, or maybe a systolic pressure of 80-90 mmHg. This allows some vital organ perfusion while minimizing the negative consequences during active bleeding.
A fine balance. And the fourth principle of DCR is to avoid dilutional coagulopathy and treat existing deficits. How do we achieve that?
We aim to avoid diluting the patient's own clotting factors by being very judicious in our use of clear intravenous fluids, both crystalloids like saline or Hartmann's, and colloids like albumin. These don't help with clotting. Instead, we prioritize the transfusion of blood products in a ratio that attempts to approximate the composition of whole blood.
Like giving back what was lost.
Essentially, yes. In practice, this often means transfusing packed red blood cells and plasma, like FFP, in roughly equal volumes, aiming for a 1.1 ratio. Some protocols also advocate for early platelet transfusion, leading to a 1.1.1 ratio of red cells.plasma.platelets. This is the concept of balanced transfusion or hemostatic resuscitation.
So blood products early, minimal clear fluids, and treating existing clotting problems.
Right. Balanced transfusion helps prevent worsening coagulopathy, but it doesn't necessarily correct a deficit that's already there. So we also need to actively treat existing problems. As we mentioned, hyperfibrinolysis, excessive clot breakdown is common in trauma. So tranexamic acid, TXA, a medication that stops this breakdown, should ideally be given as early as possible, usually within 3 hours of injury, to almost all patients with significant bleeding.
TXA? Early. What else?
Low levels of fibrinogen are also very common and critical, as fibrinogen is vital for forming stable clots. So we often administer cryoprecipitate, which is rich in fibrinogen, either empirically based on the clinical picture or guided by laboratory tests or point-of-care clotting assays like thromboelastometry, TEG, or ROTEM.
Cryo for fibrinogen and platelets.
Yes, platelet concentrates are given if the patient has a low platelet count, thrombocytopenia, or if there's evidence from tests like Tegretem that their platelets aren't functioning properly, even if the count is okay.
So constantly assessing and replacing specific factors.
Exactly. Throughout the management of a patient with ongoing bleeding under DCR principles, their clotting function should be frequently reassessed using point-of-care tests or rapid lab results. An appropriate blood component should be administered promptly based on these assessments until the bleeding has been effectively controlled.
And once the bleeding is stopped, what happens then?
Once hemostasis is achieved, the bleeding is definitively stopped. We then transition away from DCR principles. The focus shifts to more definitive resuscitation. This includes actively warming the patient if they are hypothermic, fully correcting any remaining coagulation abnormalities, carefully restoring adequate circulating volume and organ perfusion, moving away from permissive hypotension towards normal targets, and closely monitoring the patient's response to fluids and the overall endpoints of resuscitation to ensure they are adequately resuscitated while trying to minimize the risks of fluid overload and organ failure. The approach changes significantly once the bleeding stops.
That's a really comprehensive breakdown of damage control resuscitation, a critical strategy for managing patients with severe active bleeding. Now, let's broaden the scope again and talk about shock resuscitation in general. What we do once bleeding has been controlled, or in cases where hemorrhage isn't the primary cause of shock in the first place.
Okay. The immediate steps in resuscitating any patient in shock, regardless of the cause, always begin with the basics. Ensuring they have a patent, clear airway, and that they are receiving adequate oxygenation and ventilation. ABCs first.
Always ABCs.
Always. Once these basic life support measures are secure, we then focus on cardiovascular resuscitation. As we've just discussed in detail for hemorrhagic shock, this cardiovascular resuscitation takes the form of DCR while active bleeding persists.
But after bleeding control, or for other shock types.
After bleeding has been controlled, and for all other causes of shock, cardiogenic, distributive, obstructive, endocrine, or non-hemorrhagic hypovolemic, resuscitation is then primarily guided by measures of how well the tissues are being perfused. We use various monitoring tools, which we'll discuss shortly, to guide our therapy aiming to restore adequate oxygen delivery to the cells.
Okay, and what are some of the general principles that guide how we conduct resuscitation in these non-bleeding or post-bleeding situations?
Well, one really important principle is not to delay starting resuscitation while waiting for a definitive diagnosis of the underlying cause of shock. Time is critical. However, the specific timing and the types of treatments we use will, of course, depend on the specific type of shock suspected, as well as how quickly and how severely the problem has developed.
Use clinical clues initially.
Yes, a rapid clinical examination will usually give us enough information to make an initial determination of the most likely cause and guide our initial steps, even if we don't have all the answers immediately. If we're genuinely unsure about the exact cause of shock, it's generally safer to initially assume that the patient has a low circulating blood volume hypovolemia and to start with cautious fluid resuscitation while closely observing their response. Volume is often a component, as we said.
Fluids first, if in doubt.
Generally, yes, cautiously. Correction of shock is also critically important in the period leading up to and during urgent surgery for conditions other than bleeding, for example. A patient with a severe bowel obstruction who is also in hypovolemic shock from fluid losses needs their shock addressed as much as possible before going under anesthesia and surgery.
Why is pre-op resuscitation so important?
Because inadequate resuscitation in the pre- and perioperative period significantly increases the risk of serious complications. Things like a heart attack during or after surgery, worsening the systemic inflammatory response leading to more organ damage, especially acute kidney injury, and also increasing the risk of post-operative infections, blood clots like DVT or PE, and prolonging the time it takes for the gut to start working again after surgery. It just leads to poorer outcomes overall. So adequate resuscitation is vital.
Makes sense. Let's focus now on fluid therapy, which is often a cornerstone of treating many types of shock, especially hypovolemia. What are the first steps and what are the different types of fluids we might use?
Right. In almost all forms of shock, regardless of the underlying cause, the initial priority should be to address any potential hypovolemia and ensure that the heart has an adequate amount of blood returning to it to pump effectively what we call adequate preload before we start using other therapies like vasopressors or inotropes.
Why fluids before heart drugs?
Because giving medications that stimulate the heart to beat harder or faster, inotropes and chronotropes, to a heart that doesn't have enough blood filling it an empty heart, will rapidly deplete the heart muscle's own oxygen stores and can actually reduce the blood flow through the coronary arteries that supply the heart itself. It's counterproductive and potentially harmful. So correcting preload with fluids first is crucial.
Got it. How do we give fluids quickly?
The first-line treatment involves establishing good intravenous access using short, wide-bore peripheral catheters. The wider and shorter the catheter, the faster the flow rate. Long, narrow lines, like central venous catheters, actually have too much resistance to allow for the very rapid fluid infusion that's often needed initially in severe shock, although they are very useful for monitoring pressures later on.
Big pipes for fast flow. What kind of fluids?
As a general rule, the ideal fluid for resuscitation is one that most closely resembles the type of fluid the patient has lost. If the loss is primarily blood, then the best replacement is, logically, whole blood, or its components, packed red cells, plasma, platelets. We might use crystalloid fluids like saline or Hartmann's as a temporary measure while we're waiting for blood products to arrive, but blood replaces blood best.
And for non-blood losses, like dehydration or third spacing.
For other causes of shock where there's a loss of fluid other than blood, such as severe dehydration or vomiting, crystalloid solutions with an appropriate electrolyte balance are usually the first choice for resuscitation.
Crystalloids like saline or Hartmann's Ringer's lactate. What about colloids like albumin or starches? Are they better?
That's been a subject of much debate and research over the years. Interestingly, most large studies haven't shown a clear, consistent advantage of using colloid solutions over crystalloid solutions in terms of major patient outcomes like survival.
Really? I thought colloids stayed in the circulation better.
They do, to some extent, but perhaps not as much better as we once thought. Early ideas suggested you needed much less colloid than crystalloid, but trials suggest the volume benefit is less dramatic, maybe needing only about 1.3 times more crystalloid than colloid to achieve a similar intravascular volume expansion.
So not a huge difference in volume needed.
Not as big as initially thought. And given that colloids are generally much more expensive and some have potential for worse side effect profiles, like kidney injury with some older starches or allergic reactions, there's not a lot of strong evidence to support their routine use over crystalloids for initial resuscitation in most types of shock.
Stick with crystalloids mostly then.
For initial volume replacement in non-hemorrhagic shock, yes, balanced crystalloids like Hartmann's or Ringer's lactate are often preferred over normal saline, especially in large volumes, to avoid causing a hyperchloremic acidosis. Hypertonic solutions, like 5% dextrose, are generally poor at expanding the circulating blood volume because the water distributes everywhere. So they should usually be avoided in shock resuscitation unless the primary problem is specifically a loss of free water, like in diabetes insipidus, or if managing severe sodium overload.
Okay, primarily balanced crystalloids for non-bleeding volume loss.
Yeah.
What about the role of vasopressor and inotropic support in shock resuscitation? When do these medications come into play?
Right, so vasopressors and inotropes are generally not the first-line treatment for shock caused primarily by low blood volume hypovolemia. As we've already hammered home, giving these drugs when the heart doesn't have enough preload can be dangerous.
Fluids first.
Fluids first to ensure adequate filling. Vasopressor medications, drugs like phenylephrine or, more commonly, noradrenaline, norepinephrine, work mainly by constricting blood vessels, vasoconstriction, to increase systemic vascular resistance and raise blood pressure. They are primarily indicated in types of distributive shock.
Like sepsis or neurogenic shock.
Exactly. In those conditions, the primary problem is widespread vasodilation leading to a low SVR and hypotension, even though the cardiac output might be normal or even high initially. Vasopressors help counteract that vasodilation and restore blood pressure.
What if those don't work well?
In situations where the vasodilation is very severe and resistant to the standard catecholamine vasopressors, sometimes seen if the patient has underlying adrenal insufficiency or in refractory septic shock, we might consider using vasopressin as an alternative or additional vasopressor, as it works via a different mechanism.
Okay, and inotropic drugs, like dobutamine.
Inotropic medications, such as dobutamine, work by increasing the strength of the heart's contractions, improving contractility. They might be needed in cardiogenic shock, where the primary problem is pump failure, or sometimes when the heart's pumping ability becomes significantly impaired as a complication of another type of shock, such as in severe septic shock, with evidence of low cardiac output and poor perfusion, despite adequate fluid resuscitation and vasopressors.
So inotropes to boost a failing pump.
Precisely. The goal of inotropic therapy in these cases is to improve the heart's ability to pump blood effectively and thereby increase oxygen delivery to the tissues. But again, only after preload is optimized.
So the general approach is fluids first to address volume, then vasopressors for distributive shock, low SVR, and maybe inotropes for cardiogenic shock or myocardial depression and other shocks. Now, closely monitoring a patient in shock is obviously absolutely critical. What are the minimum standards of monitoring, and what are some of the more advanced techniques we might use to guide resuscitation?
Monitoring is key, you're right. The absolute minimum monitoring for any patient suspected of being in shock includes continuous monitoring of their heart rate, usually via ECG, continuous oxygen saturation monitoring, pulse oximetry, frequent measurements of their non-invasive blood pressure, NIBP cuff, and strict hourly recording of their urine output. That's the baseline.
Heart rate, SATs, BP, urine.
Yes. However, most patients who are in significant shock or who don't respond rapidly to initial measures will require more detailed and usually invasive monitoring. This often includes the measurement of central venous pressure, CVP, via a central line and continuous beat-to-beat blood pressure monitoring through an intra-arterial line, an ART line. Summary Box 2.4 gives a good overview of the different monitoring options.
Okay, let's delve a little deeper into these monitoring techniques. What kind of information can we gather from each? Starting with CVP.
Okay, central venous pressure measures the pressure in the large vein returning blood to the right side of the heart, usually the superior vena cava. It can give us an idea of the patient's fluid status and how well the right side of their heart is handling the volume returning to it.
An idea, not a definitive measure.
Exactly. It's important to understand that there's no single normal CVP value that applies to every shocked patient. A reading that's normal for one might be too high or too low for another, depending on their heart function and vascular tone. Relying on just one static CVP measurement to assess their fluid volume status can be quite misleading.
Why is that?
Because the ability of the heart ventricle to stretch and fill with blood, its compliance, can change rapidly in shock. So the CVP might not always accurately reflect the actual amount of blood filling the ventricle just before it contracts, which is the true preload.
So how is CVP useful then?
CVP is most useful when we look at it dynamically, specifically how it changes in response to a fluid challenge.
Giving a bolus and watching the CVP.
Precisely. We rapidly give a small amount of intravenous fluid, maybe 250 to 500 milliliters over 5 to 10 minutes, and observe the CVP response. A normal response might be a temporary rise of, say, 2 to 5 centitonate H2O, which then gradually returns towards the baseline level over the next 10 to 20 minutes.
What do other responses mean?
If the CVP doesn't change much or rises very little after a fluid bolus, it often means the patient is still volume depleted and likely needs more fluid, they're fluid responsive. On the other hand, a large and sustained increase in CVP after a small fluid challenge might indicate that the heart is already adequately filled or potentially struggling to handle more volume, suggesting high preload, possible cardiac insufficiency, or fluid overload. We should be cautious about giving more fluid in that case.
Okay, dynamic CVP assessment. What about monitoring cardiac output? How is that done and what does it tell us?
Monitoring cardiac output, the amount of blood the heart pumps per minute, gives us a more direct assessment of the heart's function as a pump. It also allows us to calculate other important parameters like the systemic vascular resistance, SVR, and potentially estimate preload and overall blood volume using various derived measures.
How do we measure it now? Is it still the Swan-Ganz catheter?
The use of invasive monitoring with pulmonary artery catheters, the Swan-Ganz, which directly measure pressures inside the heart and pulmonary artery, has become less common over the years. This is partly because newer, less invasive or minimally invasive techniques have been developed. Things like Doppler ultrasound, echocardiography or esophageal Doppler, pulse waveform analysis systems that analyze the arterial pressure trace, and indicator dilution methods, like using lithium or thermodilution via specialized central lines, can provide similar information about cardiac output and hemodynamics with potentially fewer risks and complications than the PA catheter.
When is CO monitoring most helpful?
Measuring cardiac output can be particularly helpful in distinguishing between different types of shock, especially when multiple types might be coexisting, like septic shock with underlying heart failure. It's invaluable in guiding the administration of fluids and vasopressors or inotropic medications by giving us real-time feedback on how the cardiovascular system is responding to our interventions. We should consider initiating cardiac output monitoring relatively early in patients who aren't responding as expected to our initial treatments, or in those who clearly have cardiogenic shock or suspected significant heart muscle dysfunction. It helps tailor therapy.
So we're looking at a combination of basic vital signs and more advanced hemodynamic parameters like CVP dynamics and cardiac output to assess the patient's overall cardiovascular status. But ultimately, as you said, our goal is to ensure that the organs are getting enough oxygen. How do we monitor systemic and organ perfusion? What tells us if the tissues are happy?
That's the crucial end goal, you're absolutely right. Restoring cellular and organ perfusion is the ultimate aim of shock resuscitation. Ideally, our monitoring would directly tell us how well oxygen is being delivered and used by the body's tissues and organs.
What are our current best tools for that?
As we've discussed, urine output is a really important, albeit delayed, hourly indicator of kidney perfusion and serves as a key marker of overall resuscitation success. The patient's level of consciousness reflects brain perfusion, but the brain often compensates well and maintains its blood flow until very late in shock, so consciousness level isn't a very sensitive early indicator of resuscitation adequacy. Currently, the best overall measures we have in routine clinical practice for assessing global tissue perfusion, particularly reflecting the perfusion of large vascular beds like the gut and muscle tissues, are markers of lactic acidosis, specifically the serum lactate level, and the base deficit calculated from an arterial blood gas analysis, and the mixed venous oxygen saturation, SVO2. Table 2.4 lists some monitors for organ systemic perfusion.
Let's talk about lactate and base deficit first. How do they reflect perfusion?
Lactic acid, as we established way back at the beginning, is produced when cells don't get enough oxygen and have to switch to anaerobic metabolism. So the degree of lactic acidosis, indicated by a high lactate level or a significant base deficit, which is a measure of the buffer needed to normalize blood pH, is a sensitive marker for both diagnosing the presence and severity of shock, and also for tracking how well our treatment is working. Is the lactate level coming down?
Is there a critical level?
A base deficit of more than 6 millimol, or a similarly elevated lactate level, is generally associated with a higher risk of complications and death. And importantly, even if a patient's vital signs seem to normalize, a persistently elevated base deficit or lactate can indicate that hidden or occult hypoperfusion we talked about earlier.
How often do we measure these?
These values are typically obtained from arterial blood gas samples, so we don't get a continuous real-time reading like we do with heart rate or blood pressure. Nevertheless, we should measure lactate and base deficit regularly, perhaps every few hours initially in any patient with shock, until they return to and remain within the normal range.
Okay, lactate and base deficit track the consequences of anaerobic metabolism. What about mixed venous oxygen saturation, SVO2? What does that tell us?
Mixed venous oxygen saturation tells us the percentage of oxygen remaining in the blood after it has passed through the body's tissues and is returning to the heart. It reflects the balance between oxygen delivery, DO2, and oxygen consumption, VO2, by the tissues.
How is it measured accurately?
An accurate measurement ideally comes from a blood sample drawn from a long central line whose tip is placed in the pulmonary artery via a PA catheter, or, more commonly now, in the right atrium of the heart. We can get reasonable estimates, usually slightly higher, from samples taken from a standard central line positioned in the superior vena cava, called SCVO2.
What's the normal range, and what do deviations mean?
A normal range for SVO2, or SCVO2, is typically between, say, 65% and 75%. The table said 50-70%, perhaps representing a wider range or older data. Let's stick with the text 50-70% for consistency. A level below 50% indicates that the tissues are extracting much more oxygen than usual because oxygen delivery is inadequate relative to demand. This is typically seen in low flow states like hypovolemic and cardiogenic shock.
Low SVO2 means low delivery or high consumption. What about high SVO2?
Interestingly, in septic shock and some other forms of distributive shock, we can often see mixed venous oxygen saturations above 70%.
Why would it be high in sepsis?
In sepsis, this often reflects the problems we discussed earlier. Either the cells are having trouble using the oxygen that is delivered, mitochondrial dysfunction, or there is significant shunting of blood past the capillary beds, meaning the blood doesn't get a chance to offload its oxygen to the tissues effectively. So the venous blood returns to the heart with a higher than expected oxygen concentration.
So high SVO2 in sepsis isn't necessarily good.
Not necessarily. In fact, in septic patients, we generally aim for an SVO2 above 70%. If a septic patient has an SVO2 below 70%, it might suggest that they have coexisting hypovolemic or cardiogenic shock contributing to the picture. Even a seemingly normal SVO2, say 65%, in a septic patient could actually be too low for their highly metabolic stressed state. So we often need to aggressively treat them, perhaps with more fluids if they seem hypovolemic based on other measures, or inotropic agents if their cardiac output is low, to push the SVO2 above that 70% target, indicating improved oxygen delivery relative to consumption.
That's complex. Are there newer ways to monitor tissue perfusion more directly?
Yes, there are newer techniques emerging that try to monitor oxygen levels and blood flow in specific regional tissue beds. Things like muscle tissue oxygen probes, near-infrared spectroscopy, NIRS, which can estimate tissue oxygenation non-invasively, and sublingual capnometry, which measures carbon dioxide levels under the tongue as an indirect indicator of local blood flow and perfusion.
Are these replacing lactate and SVO2 yet?
While these techniques are interesting and are being used in research and some specialized centers, it's not yet entirely clear if they offer a significant proven advantage over using the global markers of hyperperfusion, like base deficit and lactate, in guiding our overall resuscitation strategies and improving patient outcomes in most settings. They are still evolving.
So we're aiming for a multifaceted approach, looking at overall cardiovascular stability. HR, BP, CVP, CO, and also these global markers of tissue perfusion, lactate, base deficit, SVO2, to guide us. It sounds like knowing when to stop resuscitation is just as important, and maybe just as difficult as knowing when to start. What are the endpoints we're really looking for? When can we say resuscitation is adequate?
That's a really insightful question, and it's a critical aspect of shock management. Knowing when we've achieved adequate resuscitation can sometimes be much trickier than initiating it. Traditionally, we used fairly simple endpoints like achieving a normal heart rate, a normal blood pressure, and adequate urine output, 0.5 milli-LKHR.
The traditional vital signs.
Right. However, as we've discussed, these parameters primarily reflect the well-being of organs like the brain, lungs, and kidneys, which tend to maintain this blood flow relatively well, often at the expense of other organs, until very late in shock.
So they can look normal while other areas suffer.
Exactly. This means a patient can have seemingly normal vital signs, but still have significant ongoing underperfusion of the gut and muscle tissues. This ongoing hidden or occult hypoperfusion can continue to drive inflammation and activate the clotting system. Then, when these organs are finally adequately reperfused, it can trigger that harmful ischemia-reperfusion entry cascade, ultimately contributing to multiple organ failure later on.
So normalization of vitals doesn't equal full resuscitation?
Correct. This state of normal vital signs with continued underlying tissue hypoperfusion is that occult hypoperfusion we mentioned, and it's often manifested by a persistent lactic acidosis, high lactate-base deficit, and maybe a low or inappropriately normal mixed venous oxygen saturation. The duration a patient spends in this state of occult hypoperfusion has a significant impact on their outcome. Studies have shown that if it lasts for more than 12 hours, the risk of mortality can be dramatically increased, maybe 2 to 3 times higher.
So we need better targets.
Yes. This understanding has led to the development of resuscitation algorithms or bundles that target these global perfusion endpoints, aiming to normalize base deficit, clear lactate levels, and optimize mixed venous oxygen saturation, in addition to normalizing the traditional vital signs.
And does that work better?
There is good evidence, particularly in high-risk surgical patients and sepsis patients, that using these goal-directed resuscitation strategies, targeting these physiological endpoints, can improve outcomes, reducing mortality and morbidity compared to just aiming for normal heart rate and blood pressure.
But are there risks to pushing too hard to meet these targets?
Yes, there's always a balance. We also need to be aware that overly aggressive fluid resuscitation, particularly with crystalloids, in an attempt to achieve these targets rapidly, can sometimes lead to its own problems. Things like tissue swelling, edema, fluid buildup in the lungs, ARDS, increased pressure within the abdomen, abdominal compartment syndrome, and potentially swelling in the brain. Some patients simply cannot be fully resuscitated to entirely normal physiological parameters within, say, the first 12 or 24 hours using fluids alone without causing harm. So we need to take a very balanced, thoughtful, and often individualized approach to all our therapies as we approach these resuscitation endpoints, constantly weighing the potential benefits of further intervention against the risks. It's not just about hitting a number.
It highlights the really delicate balance we're constantly trying to achieve in managing shock. Constant reassessment is key. Let's move on now to the related topic of transfusion, which is so often a vital part of managing both hemorrhagic shock and sometimes other types too, as well as treating anemia. It's been a cornerstone of medical practice for a long time, hasn't it?
Yes, absolutely. The transfusion of blood and blood products has become a truly fundamental medical intervention since the first documented successful human blood transfusion way back in 1818.
Is it safe now?
While the risks of severe immediate transfusion reactions and transmitting serious infections are thankfully very low today in developed countries, due to huge advancements in donor screening, blood testing, and compatibility procedures, we've also come to recognize more subtle potential downsides.
Gotcha.
We now understand that there can be immunological consequences associated with receiving blood from another person. Heterologous transfusion. This can sometimes modulate the recipient's immune system in ways that might lead to increased complications, like infections, or potentially decreased survival in certain patient groups, such as those with major trauma or some types of cancer.
And it's a limited resource.
Exactly. Blood supplies rely on volunteer donors and are a precious, limited resource. Therefore, we must always use blood and blood products judiciously, ensuring each transfusion is clearly indicated by the patient's clinical needs and the potential benefits outweigh the potential risks. Table 2.5 in the source material provides a brief historical overview, highlighting some key milestones. It's quite a fascinating story of scientific progress, from Landsteiner discovering blood groups to modern component therapy.
It certainly is. Now, what are the main blood and blood products that are actually available for transfusion in modern medical practice? What's in the blood bank fridge?
Okay. Blood is collected from volunteer donors who undergo a thorough screening process, questionnaires, and basic health checks to ensure donation is safe for them and that their blood is likely to be safe for transfusion.
How much do they take?
In the UK, for example, a standard donation is typically around 450 millil, and donors can usually donate up to 3 times a year. Each unit of donated blood is then rigorously tested in the lab for evidence of key transmissible infections like hepatitis B and C, HIV types 1 and 2, HTLV, and syphilis.
And prepared in certain ways.
Yes. As a precautionary measure against variant Creutzfeldt-Jakob disease, VCJD, and also because it likely reduces some types of immune reactions in the recipient, donated blood in many countries, including the UK, is now universally leukodepleted, meaning most of the white blood cells are removed. The blood is also tested, of course, to determine the donor's ABO and rhesus D blood groups, and it's screened for the presence of any significant irregular red cell antibodies that could cause problems.
Then it's split up.
Usually, yes. The collected whole blood is typically processed into its various component parts to allow for more targeted therapy and efficient use of the donation.
What are the main components?
Well, first, there's whole blood itself, containing all the cells and plasma. However, in contemporary civilian medical practice, transfusion of whole blood is actually quite rare.
Why is that, if it's what we lose?
Mainly because separating it into components allows us to treat more patients from a single donation, giving red cells to one person, plasma to another, platelets to a third. It's seen as a more efficient use of a limited resource. That being said, there's renewed interest in whole blood, especially low titer group O whole blood, LTOWB, for trauma resuscitation, as it provides everything in a balanced way. Fresh whole blood also contains more functional platelets and clotting factors than stored components.
Okay. What's the most common component then?
That would be packed red blood cells, PRBCs. These are obtained by centrifuging whole blood to remove most of the plasma. This leaves a concentrated solution of red blood cells, typically in a volume of around 250-350 millicol, with a hematocrit red cell concentration of 50-70%.
How long do they last?
Packed red cells are stored in a special preservative additive solution, like SAGE-M, saline adenine glucose mannitol, which extends their shelf life to up to 5 or 6 weeks when stored refrigerated at 26 degrees C. Older solutions had shorter shelf lives.
Okay. Red cells for oxygen carrying capacity. What about plasma?
Fresh frozen plasma, or FFP, is the liquid component of blood, separated quickly after donation and frozen. It's rich in all the coagulation factors. Freezing preserves the activity of these factors, allowing FFP to be stored for up to 2 or even 3 years at very low temperatures, like -30 degrees C or below.
When is FFP used?
FFP is a primary treatment for patients who are bleeding due to deficiencies in multiple clotting factors, such as in liver disease, warfarin overdose reversal, though PCCs are faster, or dilutional coagulopathy during massive hemorrhage, as part of that balanced resuscitation strategy.
Does the RH type matter for FFP?
Generally less critical than for red cells, as there are very few red cells in FFP. However, RHD positive FFP can potentially sensitize an RHD negative recipient, especially women of childbearing potential, if large volumes are given. So while it's sometimes done, giving RHD immunoglobulin might be considered. Ideally, RHD negative recipients get RHD negative plasma if possible.
Okay. What's cryoprecipitate?
Cryoprecipitate, often just called cryo, is another plasma-derived product. It's made by thawing FFP slowly in the cold and collecting the precipitate that forms. This precipitate is particularly rich in certain clotting factors, specifically fibrinogen, factor VIII, factor 13, and von Willebrand factor.
So it's a concentrated source of those specific factors.
Exactly. It's stored frozen and is primarily used to treat patients with significant bleeding who have low levels of fibrinogen, hypofibrinogenemia, or, less commonly now due to specific factor concentrates, deficiencies in factor VIII, hemophilia A, or von Willebrand disease. Fibrinogen replacement is its main use in hemorrhage.
Got it. What about platelets?
Platelets are essential for forming the initial plug that stops bleeding at sites of vascular injury. For transfusion, they are typically supplied as a pooled concentrate from several donors, or sometimes as an apheresis unit from a single donor. A typical adult dose raises the platelet count significantly.
How are they stored?
Unlike red cells and plasma, platelets have a very short shelf life, usually only 5 to 7 days. And importantly, they must be stored at room temperature, around 20-24 degrees C, on a special agitator that keeps them gently moving to prevent clumping. This storage requirement makes them susceptible to bacterial contamination.
When are platelets given?
Platelet transfusions are given to patients who have a low platelet count, thrombocytopenia, and are bleeding or at high risk of bleeding, for example, before surgery. Or they might be given to patients with normal platelet counts but whose platelets aren't functioning properly, perhaps due to medications or inherited disorders.
Like patients on aspirin or clopidogrel?
Exactly. We're seeing more and more patients on antiplatelet medications. While aspirin usually doesn't cause unmanageable surgical bleeding on its own, more potent drugs like clopidogrel, ticagrelor, or prasugrel can make controlling hemorrhage very difficult. Patients on these drugs who have major bleeding or need urgent surgery might require platelet transfusions, although the effectiveness can be variable as the drug is still present.
Tricky situation. Are there other clotting products?
Yes, there are prothrombin complex concentrates, or PCCs. These are highly purified preparations derived from pooled plasma containing several vitamin K-dependent clotting factors, usually factors 2, IX, and X, and sometimes factor 7, making it a 4-factor PCC.
When are PCCs used?
Their main use is for the rapid and urgent reversal of warfarin anticoagulation in patients who have life-threatening bleeding or require emergency surgery. They work much faster than vitamin K alone. Some are also used for specific factor deficiencies.
Okay. And lastly, autologous blood. using the patient's own blood.
Right. Autologous transfusion isn't used as much now with improved safety of donor blood, but it has two main forms. One is preoperative autologous donation, PAD, where a patient donates their own blood units in the weeks leading up to an elective surgery, which are stored and retransfused back to them if needed. The other is intraoperative cell salvage, often called cell saver.
Cell saver.
During surgery where significant blood loss is anticipated, a cell saver device can collect blood lost from the surgical field, wash the red blood cells to remove debris and contaminants, and then return the concentrated red cells back to the patient. It's a way to recycle the patient's own lost red cells. It's not suitable if there's infection or malignancy in the surgical field, though.
That's a really comprehensive overview of the different blood components available. Now, thinking about red cells specifically, what are the main situations where a blood transfusion might actually be indicated? When do we decide a patient needs red cells?
It's a really important question because we want to avoid transfusion if possible due to the risks and resource issues we mentioned. The main indications for red blood cell transfusion fall into a few categories. First, acute blood loss, significant hemorrhage where the goal is twofold. Partly to replace lost volume, but more importantly to maintain adequate oxygen carrying capacity to prevent tissue hypoxia. Second, perioperative anemia.
Anemia around the time of surgery.
Yes. If a patient is significantly anemic before major surgery or becomes anemic during it, transfusion might be needed to ensure they have adequate oxygen delivery to cope with the stress of surgery and recovery, especially if they have pre-existing heart or lung disease. The threshold for transfusion here is often debated. And third, symptomatic chronic anemia.
Chronic anemia, like from kidney disease or nutritional deficiencies.
Exactly. In patients who are not actively bleeding and not facing imminent surgery, transfusion might be considered if their chronic anemia is causing significant symptoms that impair their quality of life, like severe fatigue, shortness of breath on minimal exertion, or even signs of heart strain, like angina. And if other treatments for the anemia, like iron or EPO, have failed or aren't appropriate, we generally treat the cause first if possible.
Okay, acute loss, perioperative optimization, and symptomatic chronic anemia. What about transfusion triggers? We used to hear about a hemoglobin level of 10 GDL or 100 GL as a common threshold. Is that still the standard?
No, not really. The historical practice of routinely transfusing patients to maintain a hemoglobin level above 10 GDL has been largely debunked by numerous large clinical trials over the past couple of decades.
What did those trials show?
They generally showed that using a more restrictive transfusion strategy, for example, triggering transfusion only when the hemoglobin drops below 7 or 8 GDL in most stable hospitalized patients, is just as safe, and in some cases might even be associated with better outcomes, like fewer infections or cardiac events, compared to the more liberal strategy of transfusing at a threshold of 9 or 10 GDL.
So lower is generally better, or at least not worse?
For many stable patients, yes. A hemoglobin level of 7 GDL is now a widely accepted transfusion threshold for stable, asymptomatic hospitalized patients, including those in critical care. Some guidelines even suggest 6 GDL might be acceptable in truly stable, non-surgical, asymptomatic individuals.
Are there exceptions? Where might a higher target still be considered?
There's still some controversy and ongoing research about the optimal hemoglobin threshold in certain specific high-risk patient groups. For example, patients with acute myocardial infarction, heart attack, those with severe sepsis or septic shock, or those with traumatic brain injury.
Why might they need more hemoglobin?
The theoretical rationale is that maintaining a higher hemoglobin level in these situations might improve oxygen delivery to the struggling heart muscle, the globally stressed tissues in sepsis, or the injured brain. However, the clinical evidence from trials specifically in these groups to definitively support routine use of higher transfusion thresholds, like aiming for 9 or 10 GDL, is still limited or conflicting at this stage. It's an area of active investigation. Table 2.6 in the source provides a summary of some general perioperative transfusion criteria based on HB levels and clinical context.
So, generally restrictive, Berger 7 or 8, but consider the individual patient context, especially in high-risk situations. Understanding blood groups is obviously absolutely essential for ensuring safe blood transfusions. Can you give us a brief refresher on the key principles of the ABO and rhesus blood group systems, the ones that matter most?
Absolutely. These are fundamental. Human red blood cells have literally hundreds of different antigens on their surface, but the ABO system and the rhesus system are by far the most clinically significant in transfusion practice because mismatches in these systems are highly likely to cause severe hemolytic transfusion reactions.
Let's start with ABO. How does that work?
The ABO system is determined by three main gene variants, or alleles, A, B, and O. These genes code for enzymes that add specific sugar molecules onto proteins and lipids on the surface of red blood cells. The A gene leads to the A antigen, the B gene leads to the B antigen, and the O gene is effectively inactive, leading to no A or B antigen, sometimes called the H antigen.
So you inherit combinations of these.
Right. Since we inherit one gene from each parent, there are 6 possible genetic combinations: AA, AO, BB, BO, AB, OO, but these result in only 4 common blood types or phenotypes based on the antigens present. Type A has A antigen, type B has B antigen, type AB has both A and B antigens, and type O has neither A nor B antigen.
And the antibodies, that's the crucial part for reactions, right?
Exactly. A unique and critical feature of the ABO system is the predictable presence of naturally occurring antibodies in the plasma, or serum, of individuals against the ABO antigens that they lack on their own red blood cells.
Can you give examples?
Sure. People with blood type A have anti-B antibodies in their plasma. People with type B blood have anti-A antibodies. People with type O blood, lacking both antigens, have both anti-A and anti-B antibodies. And people with type AB blood, having both antigens, have neither anti-A nor anti-B antibodies in their plasma. Table 2.7 in the text summarizes this nicely, including frequencies.
This explains universal donors and recipients.
Yes. People with type O blood are often called universal red cell donors because their red cells lack both A and B antigens, so they won't typically be attacked by the anti-A or anti-B antibodies in a recipient's plasma, though plasma compatibility is also a consideration for whole blood plasma. Conversely, people with type AB blood are often called universal recipients for red cells because their plasma lacks both anti-A and anti-B antibodies, meaning they can generally receive red blood cells of any ABO type without causing an immediate major reaction.
Okay, that's ABO. What about the rhesus system, the positive-negative part?
The rhesus system is another complex system with many antigens, but the most important one, by far, is the rhesus D antigen, often just called RHD. People who have this D antigen on their red blood cells are designated RHD positive. In populations like the UK or US, about 85% of people are RHD positive.
And the rest are negative.
Yes, those who lack the D antigen are RHD negative, making up about 15% of the population. Now, unlike the ABO system, RHD negative individuals do not naturally have antibodies against the D antigen, anti-D, in their serum.
So how do they develop antibodies?
They can develop anti-D antibodies if they are exposed to RHD positive red blood cells. This exposure can happen through transfusion of RHD positive blood, or importantly during pregnancy if an RHD negative mother is carrying an RHD positive baby. Some fetal red cells can cross the placenta into the mother's circulation, usually during delivery, sensitizing her immune system.
And why is that sensitization dangerous?
Because once these anti-D antibodies are formed, they are usually IgG antibodies, which can cross the placenta in subsequent pregnancies. If the mother carries another RHD positive fetus, her anti-Unity antibodies can cross the placenta, attack the fetus's red blood cells, and cause potentially severe hemolytic disease of the fetus and newborn, HDFN, which used to be called erythroblastosis fetalis. This can lead to severe anemia, jaundice, heart failure, hydrops fetalis, and even death if untreated.
Which is why RHD negative mothers get ROJAM injections.
Exactly. Prophylactic RHD immunoglobulin, ROJAM, is given to RHD negative mothers during pregnancy and after delivery of an RHD positive baby to prevent them from forming these anti-MyAD antibodies in the first place. It's been a hugely successful public health intervention. There are other minor blood group antigens like KEL, Duffy, KID systems that can sometimes cause delayed transfusion reactions or HDFN, but ABO and RHD are the big players.
So getting the ABO and rhesus D types right is absolutely critical to avoid these potentially devastating reactions. What exactly happens in the body if there is a mismatch, particularly an ABO mismatch? What are the signs and symptoms of that acute hemolytic reaction?
An ABO incompatible transfusion is a medical emergency. It happens when the recipient's preformed anti-A or anti-B antibodies bind strongly to the corresponding A or B antigens on the transfused donor red blood cells. This triggers a rapid and massive activation of the complement system, a part of the innate immune system.
Complement activation, what does that do?
It leads to the rapid destruction of the transfused red blood cells right within the bloodstream intravascular hemolysis. This releases large amounts of free hemoglobin and red cell debris into the circulation, which is highly toxic. It also triggers a massive inflammatory response with release of cytokines.
What does the patient experience? How would we recognize it?
The clinical signs and symptoms can appear within minutes of starting the transfusion. The patient might suddenly develop fever, chills, shaking, rigors, pain in their back or flank, where the kidneys are, chest pain, shortness of breath, a rapid heart rate, a drop in blood pressure, hypotension leading to shock, nausea, vomiting, and sometimes oozing from IV sites or wounds due to disseminated intravascular coagulation, DIC. In an anesthetized patient, the only signs might be unexpected hypotension, uncontrolled bleeding, or the appearance of hemoglobin in the urine, hemoglobinuria, making it dark, red, or brown.
Sounds terrifying and life-threatening.
It absolutely is. Severe acute hemolytic reactions due to ABO incompatibility can rapidly lead to shock, acute kidney failure, DIC, multiple organ failure, and death if not recognized and managed immediately by stopping the transfusion and providing intensive supportive care. Reactions due to mismatches in other blood group systems are usually less severe, often causing extravascular hemolysis, destruction of red cells outside the blood vessels, mainly in the spleen, leading to jaundice and anemia developing more slowly, but they can still be significant.
What about febrile reactions? Are they dangerous?
Febrile, non-hemolytic transfusion reactions, FNHTRs, are more common and much less dangerous. They are thought to be caused by the recipient's immune system reacting to residual white blood cells or cytokines present in the transfused blood component. They typically cause fever, chills, and sometimes mild shortness of breath, usually starting within an hour or two of the transfusion. While usually benign, if a patient develops a fever during a transfusion, the transfusion must be stopped immediately, and the reaction investigated to rule out the possibility of a more serious hemolytic reaction or bacterial contamination of the blood unit. These febrile reactions are much less frequent now with universal leukodepletion.
Stop the transfusion first. Ask questions later if a reaction is suspected. So how do we make absolutely sure that the blood being given is compatible with the patient's blood before we start? That's where the process of cross-matching comes in, doesn't it?
Exactly. Cross-matching is the final critical safety check performed in the blood bank laboratory before a unit of red blood cells is issued for a specific patient. It follows the initial ABO and Rhesus-D typing of both the donor unit and the recipient's blood sample.
What does the cross-match actually involve?
In its full form, it involves mixing a sample of the recipient's serum or plasma, which contains their antibodies, with a sample of the donor's red blood cells. The laboratory scientist then looks for any evidence of agglutination, clumping, or hemolysis, red cell destruction. This confirms ABO compatibility and also detects most clinically significant antibodies the recipient might have against other antigens on the donor red cells, like Rh, Kel, Duffy, KID antigens.
How long does a full cross-match take?
A standard full cross-match, including the antibody screen and compatibility testing, typically takes around 45 to 60 minutes to complete properly.
What if we need blood faster than that? In an emergency?
In more urgent situations, there are faster options. If the patient's blood type is known and they have a recent negative antibody screen, the lab might issue type-specific blood. This means red cells that are ABO and RHD compatible with the recipient, but haven't undergone the full cross-match procedure against their current sample. This can usually be available within 10 to 15 minutes.
And in a true crash emergency, like massive trauma bleeding?
In dire emergencies, when there's simply no time for typing or cross-matching, we have to resort to using Group O red blood cells, the universal donor type. Critically, for females who are potentially of childbearing age, we must use O-negative blood to avoid the risk of Rh desensitization. For males or females definitely past childbearing age, O-positive blood might be used if O-negative supplies are short, as sensitization is less consequential for them.
O-negative for emergencies, especially for women.
Yes. But regardless of the urgency or the type of blood component being given, it is absolutely vital. I cannot stress this enough to ensure that the correct patient receives the correct unit of blood. Procedural errors at the bedside are the most common cause of fatal ABO incompatible transfusions.
The final check at the bedside.
Yes. It requires meticulous adherence to protocol. Typically, 2 trained healthcare professionals must independently verify the patient's identity, using name, date of birth, hospital number, wristband, against the details on the blood transfusion request form or prescription, and against the details on the compatibility label attached to the donor blood bag itself. Additionally, the unique serial number on the donor blood bag must be checked against the number on the patient's blood transfusion issue slip or electronic record. Strict adherence to these final bedside checks is the single most important step in minimizing the risk of catastrophic ABO incompatibility reactions.
Meticulous checks are non-negotiable. Beyond these immediate compatibility reactions, what are some of the other potential complications or risks that can arise from receiving a blood transfusion?
The complications of blood transfusion can be broadly categorized into those related to a single or small number of transfusions, and those more typically associated with massive transfusion, receiving very large volumes, often defined as 10 units of red cells in 24 hours, or replacement of the entire blood volume.
Okay, what are risks from single or few units?
These include the incompatibility reactions we've just discussed, hemolytic, febrile, allergic, ranging from mild hives to severe anaphylaxis. Then there's the risk of transmitting infections, although this is now very rare in countries with rigorous screening. Potential infections include bacterial contamination of the unit, especially platelets stored at room temperature, viruses like hepatitis B, C, HIV, extremely rare now, and parasites like malaria or babesiosis in certain regions. Other potential issues include air embolism if air enters the line, thrombophlebitis, inflammation of the vein at the IV site, and a serious complication called transfusion-related acute lung injury, or TRALI.
What's that?
TRALI is a form of acute lung injury that occurs within about 6 hours of a transfusion, usually of plasma containing products like FFP or platelets. It's thought to be caused mainly by antibodies in the donor's plasma, reacting with the recipient's white blood cells, leading to inflammation and fluid leakage into the lungs. It causes respiratory distress and hypoxia and can be life-threatening, requiring supportive care, often ventilation. Using plasma primarily from male donors or never-pregnant females has reduced its incidence.
Okay. What about complications specifically related to massive transfusion?
Massive transfusion brings its own set of physiological challenges on top of the risk of individual units. These include coagulopathy, due to dilution of the patient's own clotting factors and platelets by large volumes of resuscitation fluids and stored red cells, which lack functional platelets and factors, and also consumption of factors due to ongoing bleeding and trauma itself. Hypocalcemia, low calcium, occurs because the citrate anticoagulant used in blood bags binds to the patient's calcium. Hyperkalemia, high potassium, can happen due to the release of potassium from older stored red blood cells. Paradoxically, hypokalemia, low potassium, can sometimes occur later as cells recover and take potassium back up. And hypothermia is common because large volumes of cold blood products are infused rapidly. These metabolic and physiological derangements contribute to that lethal triad or diamond we mentioned earlier: coagulopathy, acidosis, hypothermia, hypocalcemia,
And long-term transfusion.
Yes, patients who receive repeated transfusions over months or years, like those with thalassemia or sickle cell disease, can develop iron overload, as each unit of red blood cells contains about 200-250 milligrams of elemental iron, and the body has no efficient way to excrete excess iron. This requires monitoring and iron chelation therapy.
Managing coagulopathy problems with blood clotting seems to be a recurring and critical theme in both severe hemorrhage and massive transfusion. What are the key principles for managing transfusion-related coagulopathy, specifically during massive bleeding?
Right, it's central to survival in massive hemorrhage. Correcting coagulopathy generally isn't needed if a patient isn't actively bleeding and isn't about to undergo surgery or an invasive procedure. However, it's almost inevitable that problems with clotting will occur during major hemorrhage, and these need to be anticipated and actively managed as part of the resuscitation.
Prevention is key.
Prevention of dilutional coagulopathy is a central plank of damage control resuscitation, DCR, in actively bleeding patients. That's why we emphasize that balanced transfusion strategy, trying to deliver components in a ratio that approximates whole blood, like 1.1.1 for RBCs.plasma.platelets, and minimizing the use of crystalloids or colloids if possible during active bleeding.
But balanced transfusion might not fix an existing problem.
Correct. Balanced transfusion helps prevent things getting worse through dilution, but it doesn't necessarily correct a coagulopathy that has already established due to consumption of factors, fibrinolysis, or the effects of shock, acidosis, and hypothermia. So we need to actively treat the specific deficits.
How do we do that?
As we discussed under DCR, most patients with major traumatic bleeding are hyperfibrinolytic, breaking down clots too quickly. So giving tranexamic acid, TXA, an antifibrinolytic drug, empirically and as early as possible, within 3 hours, is crucial. Low fibrinogen is also very common and critically important, as fibrinogen is essential for clot strength. So giving cryoprecipitate, rich in fibrinogen, or a fibrinogen concentrate, is often necessary, guided either empirically in massive transfusion protocols or, ideally, by laboratory tests like fibrinogen levels, or point-of-care thromboelastometry to GROTEM, which can assess clot strength.
And platelets.
Yes, platelet concentrates are given to maintain an adequate platelet count, often aiming for 50 by 109L or maybe 100 in critical bleeding or neurotrauma, and also if TEGRA-TEM suggests platelet dysfunction.
So the targeted approach based on likely or measured deficits.
Exactly. The patient's clotting function should be frequently assayed using point-of-care tests or rapid lab results during massive hemorrhage. And specific components, FFP for general factor replacement, cryofibrinogen concentrate for fibrinogen, platelets for platelets, should be administered promptly based on those results, alongside ongoing balanced component therapy until the bleeding is controlled. Correcting acidosis, hypothermia, and hypocalcemia is also vital, as these all impair coagulation.
A very dynamic and proactive approach is needed. Finally, let's touch briefly on the idea of blood substitutes. They sound like they could solve many of the problems associated with donor blood. What's at the current status of research in this field? Are they close to reality?
Blood substitutes are indeed a very attractive theoretical alternative to traditional blood transfusion. They could potentially overcome issues like the need for blood group matching, the risk of transfusion-transmitted infections, the immunological complications, and the logistical challenges of collecting, storing, and distributing donor blood, which is also a finite resource.
What types are being developed?
There are several different types of oxygen-carrying blood substitutes currently under investigation, mostly in preclinical animal studies or early-phase human clinical trials. They generally fall into two main categories: biomimetic substitutes, which try to mimic the natural oxygen-carrying function of hemoglobin within red blood cells. These are typically based on modified hemoglobin molecules. And abiotic substitutes, which are synthetic chemical compounds capable of carrying oxygen, primarily based on perfluorocarbons, PFCs.
Hemoglobin-based ones sound logical.
Hemoglobin is the obvious candidate, yes. Various approaches have been tried, like modifying hemoglobin extracted from human or animal blood, or producing recombinant hemoglobin. However, early generations of these hemoglobin-based oxygen carriers, HBOCs, ran into problems with toxicity, particularly vasoconstriction, causing high blood pressure, and kidney damage, possibly because the free hemoglobin scavenges nitric oxide, a key vasodilator. There is one free hemoglobin solution available in some regions with limited blood access, but newer, more sophisticated engineered HBOC molecules are still in clinical trials trying to overcome these issues.
What about the synthetic PFCs?
Perfluorocarbons are inert chemicals that can dissolve large amounts of oxygen. Second-generation PFC emulsions are also showing some potential in clinical trials. They require the patient to breathe very high concentrations of oxygen to load the PFCs effectively, and they don't have the same biological functions as hemoglobin beyond oxygen transport.
So are any close to widespread use?
While there has been decades of research and some progress, a universally applicable, safe, effective, and widely adopted blood substitute that can fully replace donor red blood cells in all clinical situations is unfortunately not yet a reality. It remains a significant challenge, though research certainly continues. For now, judicious use of donor blood components remains the standard of care.
This has been an incredibly detailed and insightful exploration into the really complex world of shock, hemorrhage, and transfusion. Thank you so much for shedding light on these critical concepts today.
Yeah.
It's truly fascinating and frankly a bit daunting to see how intricate and interconnected the body's responses are in these high-stakes situations.
It's been a pleasure, and you're right. Understanding these fundamental principles, the pathophysiology, the classifications, the treatments, the monitoring is absolutely essential for anyone involved in caring for critically ill or injured patients. Appreciating the challenges the body faces and the complexities involved in managing these conditions is key.
So just to quickly recap our deep dive today, we've explored how shock, that state of inadequate tissue perfusion, sets off a devastating cascade of events right down to the cellular level, and how the body tries to compensate. We've broken down the 5 main classifications of shock, hypovolemic, cardiogenic, obstructive, distributive, and endocrine, each with its unique causes and physiological fingerprint.
We also looked at the serious downstream consequences if shock isn't reversed quickly. Things like unresuscitatable shock, that dangerous ischemia, reperfusion injury, and the dreaded multiple organ failure.
Right. And we discussed how crucial it is to recognize the often subtle signs of early or compensated shock, and the pitfalls of relying solely on traditional vital signs like blood pressure. Then we turned our attention specifically to hemorrhage, stressing the absolute priority of stopping the bleeding first, and delving deep into the principles of damage control resuscitation, that paradigm shift in trauma care.
And finally, we navigated the complexities of blood transfusion, its indications, and importantly, one not to transfuse based on restrictive triggers, the vital importance of blood groups and meticulous cross-matching procedures, the potential complications from reactions to massive transfusion effects, how to manage coagulopathy during bleeding, and that ongoing quest for effective blood substitutes.
And it's so important, as you've highlighted throughout, to remember that these aren't isolated topics. Shock, hemorrhage, coagulation, inflammation, transfusion, they're all deeply interconnected. And a comprehensive understanding of these relationships is absolutely crucial for effective clinical decision-making in these critical, time-sensitive situations.
Couldn't agree more. It's about seeing the whole physiological picture.
Absolutely. And as we wrap up this deep dive, here's something perhaps to think about. How the body's own initial attempts to compensate in early shock, that clamping down and prioritizing flow, can sometimes mask the true severity of what's happening underneath, a silent struggle that really highlights the critical need for vigilance, suspicion, and appropriate monitoring beyond just the basic vital signs. This intricate interplay of physiological responses truly underscores the delicate balance the body walks between survival and systemic collapse. It makes you wonder, what other seemingly minor initial symptoms out there might actually be red flags for a much more serious underlying condition that needs urgent attention? Definitely food for thought. Join us next time for another in-depth exploration here on The Deep Dive.